the first point to be remembered for this particular organism, hi Sushant, hi Manoj, would be that इसका जो capsule होता है वो खुद ही immunity को suppress कर रहा होता है. I mean the biggest problem with this organism is that because the capsule will be inhibiting phagocytosis, so you will notice that when I'll be discussing with respect to the lumbar puncture of this patient, I'll be saying that the CSF cell count of the patient is normal. On one hand, I'm saying person is having meningitis, so we expect some pleocytosis, we expect that the cell count in the patient should be elevated. जबकि ऐसा नहीं होता है in cryptococcal meningitis. In majority of cases, the CSF of the patient will be having either a normal count or a slightly increased count. Yep, doc. We'll talk about, like I said, no, this is a topic which has been asked in recent NEET PG and FMG में तो आता ही आता है. So message number one is that if you encounter a question where I'll talk about a AIDS positive drug driver and then mention features of meningeal signs and say that the CSF cell count is normal or is slightly elevated, don't be surprised. I mean, meningitis, cryptococcal meningitis, we need specialized tests, and we'll talk about those specialized tests in a while. Very good evening, Muhammad Sajad, then Dr. Anu, SS, I'll do that for FMG, and Keshav, MA, sorry I missed your message. Yeah, you there. So you did provide me very good inputs for that NEET PG discussion. Very good evening, Anshu. So the message is that this is a nasty bug and this would be producing melanin, which is why that the lesions in the brain that you can see, these are cryptococcomas, and the cryptococcomas would be appearing black in color. So normally we read about some fungi, like this is a yeast-like fungi, but we read about fungi which are gonna produce melanin. This can also produce melanin, which is why the cryptococcomas will look relatively black in color. The third speciality of this organism would be, from microbiology perspective, would be that this is urease positive. I mean, this organism produces two enzymes, urease as well as phospholipase. The importance of knowing that is very clear, that phospholipase will cause the inflammatory cascade to be stimulated, which is why there would be a lot of inflammation in the brain, and the mortality rate with this infection can go up to more than 50%. I mean, before antiretroviral therapy was started for AIDS, most patients used to die within 1 year. Now, obviously, with the advent of CAR, the chances of this happening would be relatively less. Yes, Akash, Ashirwad, blessings, everything is there. तो आप मुझे बताओ यार, आई थिंक यू गाइज हैव रेड अबाउट क्रिप्टोकोकस मल्टीपल टाइम्स इन माइक्रोबायोलॉजी. तो इसकी वैरायटीज होते हैं, इसके सब स्पीशीज होते हैं, क्रिप्टोकोकस न्यूफॉर्मेंस, क्रिप्टोकोकस गैटाई. सो द क्वेरी फॉर यू गाइज इज, आई मीन दैट्स अ क्वेश्चन फ्रॉम माय साइड बिफोर वी गेट स्टार्टेड फॉर टुडे. I mean, ask you about urease positive organisms also, but before that, can you tell me which variety of Cryptococcus occurs in immunocompetent patients? I repeat my query once again for those of you, because we're not doing this in a question and answer sense, that which species complex of Cryptococcus would be the one that you encounter in an immunocompetent patient? Because normally to AIDS positive patient या HIV positive patient में we're gonna be studying this infection. So the query is, which variety would you be encountering in an immunocompetent patient? And your answer in this particular case, I did not get any comments there. Akash, Umesh, very good evening. Don't be surprised if you read about immunocompetent patients, then the answer would be given as Cryptococcus gatti. I repeat that again, the commonest variety that we encounter is obviously Cryptococcus neoformans, so I will speak about neoformans. But if he says cryptococcal meningitis in an immunocompetent patient, yep, possible. It's not that Cryptococcus gatti will not occur in immunocompromised patient. ये दोनों में होता है, immunocompetent में भी होता है और immunocompromised में भी होता है. The bottom line is neoformans occurs only in patients who are immunocompromised. But when it comes to gatti, this would be found in both immunocompetent as well as in immunocompromised patients. Then they'll ask you for, yeah, I will do that. पढ़ो सर, baseline data है, माइक्रोबायोलॉजी का सिंपल सा टॉपिक है, and this is asked extensively in the exam, तो हम डिस्कस कर रहे हैं. Okay, so urease positive organisms कौन कौन से होते हैं? तो उसके लिए एक निमोनिक है, दो आई थिंक आप लोगों ने पढ़ा होगा, and there would be lot of mnemonics available online. I mean, you attend so many classes. But then let me just mention from my perspective, urease positive organisms that you should be aware of would be punch by is the mnemonic for that. P would be standing for Proteus, that's the organism having swarming motility. Proteus mirabilis causes alkalinization of urine and causes that stagon calculus, so you know that. Then U would be for ureaplasma ureolyticum. This is the same nasty organism which causes UTI and can cause reactive arthritis. It can cause joint pain, reactive arthritis, can't walk, No, sir. No, it is not that Geti was called as neoformans. Cryptococcus is of two varieties. There are two subspecies. There are two species complex. There are two species complex of Cryptococcus. One is called as Cryptococcus neoformans, and the second one is called as Cryptococcus geti. So both are not the same. It's not an older name. Both are two different species complexes. Then Ureaplasma ureolyticum is that nasty bug that you eat with reactive arthritis. Then for N would be nocardia. This is the organism which you read as one of the causative agents for development of brain abscess, though usually the number one cause of brain abscess is going to be anaerobes. Then C would be obviously for what we are studying, that's going to be Cryptococcus. And then is that H, which is Helicobacter pylori, so that is no big deal. I'm left with B and Y, so two more organisms to go, and then we talk more details about Cryptococcus. B would be for Brucella. There are various varieties of it, Brucella abortus, Brucella suis, so they are also urease positive. And Y would be an organism which can contaminate the blood bag, BAG, blood bank नहीं बोल रहा, blood bag को contaminate कर सकता है. So if blood transfusion is not given within the stipulated time period of 3 to 4 hours, then a person can develop sepsis due to this particular bacteria, because this bacteria can grow in the refrigerator of blood bank at 4 degrees Celsius, that is Yersinia enterocolitica. So one, you should be aware of urease positive organisms, that is punched by the mnemonic which I mentioned, Proteus, Ureaplasma ureolyticum, Nocardia, Cryptococcus, H. pylori, Brucella and Yersinia, and you should be knowing about the diseases that these organisms would be causing. Apart from this, I said this nasty bug, there are two varieties of it, neoformans and geti. It has a capsule. तो ये capsule की importance क्या है कि भाई ये जो है ये security system को suppress करता है, and therefore CSF count of the patient would be normal. Melanin, that is cryptococcomas in lungs or in the brain specimen, will be black. Phospholipase A2 बनाता है, so it will cause local inflammatory damage, and it's a urease positive organism as well. Now we're going to talk about कि ये spread कैसे करता है. So query for you guys here. I have a couple of guys in the chat. Why and how does this organism spread? So the number one, number one reason for spread of Cryptococcus, which you should be aware of, is, yes guys, if you can just quickly comment in the chat why this organism would be, or how would this be spreading. So your answer would be pigeon droppings. This is gonna spread via the avian excreta. That's the first pigeon droppings, and they get mixed with dust. And in India is a very dusty country, so that's the inhalation of dust via the nasocribiform plate will go into the brain, and that will cause problems in a patient. So with avian excreta, the subtype that is going to be transmitted is Cryptococcus neoformans. But there is a second variety of this also, which I told you is Cryptococcus geti. तो आपने मुझे बताना है कि how does Cryptococcus geti spread, if you've read that in microbiology. Yes, pigeon droppings, that is avian excreta, that is perfectly fine. Inhalation, that is spread, that's okay. It will obviously go by inhalation. The pathogenesis means that Cryptococcus neoformans or Cryptococcus geti will go into the body via inhalation route, but then after inhalation it will go to lungs, and from the lungs it will then go to the brain and will cause cryptococcomas in the brain, cryptococcomas in the lungs as well, and can spread to the skin also. That's okay. But then how does Cryptococcus geti spread? तो आपका जो आंसर रहेगा that would be decaying wood. So please remember, decaying vegetation, fungi जो होते हैं, yeast like fungus जो है, that would be decaying wood. Of which tree? That is eucalyptus tree. So if you are going to be studying for, let me say, INICET exam, or you're going to be studying for the FMJ exam, you should be knowing both of these datas. Traditionally we talk about neoformans, that is avian excreta, but then the second one is decaying wood of the eucalyptus tree, that is via which the Cryptococcus geti would be transmitted. अब जब ये बॉडी में चला जाता है, राइट, इट हैज टू क्रॉस द ब्लड ब्रेन बैरियर एंड रीच इनटू द ब्रेन. तो ये ब्रेन तक पहुंचता कैसे? नॉर्मली ब्लड ब्रेन बैरियर शुड नॉट बी अलाउइंग एनीथिंग टू पास बाय, बट दिस फेलो yeast like fungus is able to cross the blood brain barrier. So there I've mentioned the concept of Trojan horse. If you watch that movie Brad Pitt ki Troy, there's the Trojan horse in which the soldiers are hiding and they attack. So you can take this to be representation of any macrophage, and inside this macrophage Cryptococcus is hiding. You can take this as macrophage, and inside this macrophage the Cryptococcus is hiding, so we call it Trojan horse, and it is able to, it is mainly counted in the subtropical area. So this organism is gonna get an access via the macrophages itself into the brain and will cause damage subsequently. Cryptococcomas in the brain spreads over into the CSF, and then cryptococcal meningitis could be developing in a patient. Apart from that, dissemination to the skin can also be happening. So That's where the Trojan horse comes in, or the pathogenesis component comes in. And what would be the manifestations in the patient? The manifestations are mainly going to be in the form of meningoencephalitis, or there's going to be pneumonia, or there's going to be meningeal signs developing in a chap. So let's look at what are going to be the clinical features. And most MCQs on this topic will begin in your exam with the okay, thank you, doctor. Thank you so much. Hi, Dheeraj. Good to hear from you. And the question will begin by describing a AIDS positive truck driver. Most of the time, I mean, immunocompromised, that's what they are, they love to ask, or they just say HIV positive patient, and then they will develop or they will tell you regarding features of meningitis. The spread of the disease may occur over days, but don't be surprised, it may occur over weeks. And why that's important is because traditionally I've told you that spread over weeks for meningitis is tubercular meningitis, but because this is a fungal infection, it can develop slowly as well. Then it's going to be standard manifestations. There would be headache, vasogenic versus cytotoxic cerebral edema. Herein we can differentiate on the basis of radiological findings, and then a simple hack I'll tell you is that vasogenic cerebral edema is seen with like brain tumor or neurocysticercosis, where you have inflammatory changes in the brain. Whereas if cytotoxic मतलब stroke के बाद में, so stroke के बाद में जो develop करता है, that would be cytotoxic cerebral edema. The appearance of both of them would be different because you would have a lesion like a brain tumor or neurocysticercosis present, which will help in differentiating between the two. And then contrast enhancement would also let you know regarding especially the vasogenic cerebral edema present in the case. And the treatment for both of them is different. Vasogenic is going to be treated with steroids, whereas when it comes to cytotoxic, we'll be using mannitol. So you get the standard features, but don't be surprised if meningeal signs are not given in the question. I mean, traditionally we always read about nuchal rigidity in meningitis, but cryptococcal meningitis, there is a possibility that in the question CSF count can be normal, meningeal signs may be present or may not be present. And then another problem that can develop in the person would be development of sudden onset blindness. So this has a subacute presentation, that's okay, but along with the subacute presentation, blindness is a possibility. And well, most of the time the scenario given in the exam would be AIDS positive, but other scenarios which can be given and you should be knowing is like he could describe a patient who's having a blood cancer, because there also the immunity part would be hampered. Or you might say patient has undergone solid organ transplantation. It might be like a kidney transplantation, is on immunosuppressive medication. Or you might say that this is a known case of diabetes mellitus. So I mean, it's not always AIDS positive cases. Malignancy, solid organ transplantation or diabetes mellitus might be predispositions where he might describe regarding the development of this infection. Now a query which I think should be useful for those of you who are going to be sitting subsequently for INICET exam would be that how do you differentiate between the lung involvement of Cryptococcus? Yep, frequent lumbar puncture. That's a good input, Dr. Saurabh. Thanks for that. But how in a multiple choice question in your exam you will differentiate between cryptococcal infection of the lung versus that of histoplasma, because both would be fungal infections developing in the lung. So in case there is a development of pneumonia with respect to histoplasma and with respect to Cryptococcus, the main differentiating feature will be that if he mentions regarding mediastinal lymphadenopathy in the MCQ, then mediastinal lymphadenopathy with obviously a presentation of pneumonia, I'll just write both the things together. If pneumonia and mediastinal lymphadenopathy is given together in a patient who's having a fungal infection due to malignancy, solid organ transplant, diabetes mellitus, then you should think in terms of histoplasmosis. Though he will obviously give you that standard image of histoplasmosis where you would see those intracellular parasites inside those big macrophages, but the point is on a chest x-ray, if he just mentions radiologically that there is a mediastinal lymphadenopathy present, then you should think in terms of histoplasmosis as one of the possibilities. On the other hand, bilateral infiltrates can be seen or normal x-ray can also be present. And the peculiar thing is कि ये जो skin के lesions हैं, because disease फैल जाता है, so those skin lesions which are present in this condition, they can resemble molluscum contagiosum. So I think people who endured the NEET PG question recently, they would be much more comfortable listening to my point here, and that's one of the reasons I decided to get into this discussion, because the questions MCQs that were asked were having histoplasmosis in the options also in Cryptococcus, and both were having features of lung involvement. So in a AIDS positive patient with a lung involvement and then subsequently there is a skin lesion, how do you know it is histoplasma versus Cryptococcus? One hint is, I mean histoplasma, there is going to be a mediastinal lymphadenopathy described, would not be given with respect to Cryptococcus. And then skin lesions per se are specifically described which resemble molluscum contagiosum, वो जो umbilication है, that pearly lodules present, that is gonna be Babinski sign या extensor plantar होता है, बहुत baseline सा data है बोला. हाँ जी. Sarcoidosis in X-ray in histoplasmosis. Okay, doctor, I think we should not mix two diseases here. If you talk about features of sarcoidosis or histoplasmosis, grossly different. The sarcoidosis will have that classical 1, 2, 3 sign. Then we get that galaxy sign on a CT. So grossly different features would be present. If in doubt, you can do a biopsy for sarcoidosis. And histoplasmosis, obviously, you can do a bronchoalveolar lavage or a lymph node biopsy, and you would be able to differentiate between the two. ओके गाइस, सो द मेन मैसेज इज, पहली बात तो कि इसका डायग्नोसिस करने के लिए आपको सीधा एमआरआई आंसर नहीं करना है. जो रैपिड डायग्नोस्टिक मेथड है वो तो इंडिया इंक है. बट देन द पॉइंट इज इंडिया इंक टेस्ट कैन बी नेगेटिव ऑल्सो. सो द क्वेश्चन इज ओपन टू यू गाइस. प्लीज कमेंट इन द चैट बॉक्स विद रिस्पेक्ट टू व्हाट टेस्ट वुड यू बी राइटिंग सेकंड फॉर डायग्नोसिस ऑफ क्रिप्टोकोक्कल meningitis in any patient. The rapid diagnostic technique would be that CSF you take and then you stain it with India ink. But this can be negative if the fungal burden is relatively lesser. तो अगर फंगल बर्डन कम है और CSF इंडिया इंक जो है वो नेगेटिव आ रहा है, नेगेटिव स्टेन है, तो अगला टेस्ट क्या करते हैं? यस गाइस, आई थिंक ये FMG एग्जाम में भी पूछा था और आगे वाले एग्जाम में पूछ सकते हैं. Okay, so what we can do subsequently in the patient is, okay, one is our latest, okay, Saurabh is giving a very, very technical answer here, which is definitely making sense, which is that, I mean, obviously we'll check for the CSF sugar and the protein, but one of the most important tests for diagnosis of this patient would be cryptococcal antigen. It is, yeah, we can read about mucicarmine stain, that is okay, but then again the point is mucicarmine stain is dependent on the experience of the microbiologist and the interpretation part. So how can you be sure? Your answer is CRAG. CRAG is cryptococcal antigen. This cryptococcal antigen we'll be doing on the CSF. So we have a CSF ELISA for cryptococcal antigen, which would help you identify this, and now this test is available even with respect to blood also, because ultimately the infection will go via blood into the brain of the patient. So it is not that we need to do only a lumbar puncture and then make a diagnosis. It's after all a hematogenous dissemination. So the main point is CRAG is to be answered, that is cryptococcal antigen for this patient in CSF ELISA or in the blood of this patient. In one of the previous year FMG exams, I think they deliberately did not mention the word CSF ELISA, and they rather use this term, that is lateral flow assay. So that's okay. I mean, you know, the first answer is always CRAG, and that's what I wanted you to learn for diagnosis of this. But then lateral flow assay can be present. As far as the CSF findings are concerned, the cells in the CSF of the patient can be deliberately normal also. Why normal? Because I told you that the macrophage is, I said the capsule will inhibit, the capsule is gonna inhibit the immune response. Then as far as sugar is concerned, the sugar is usually normal or slightly low in a person who's having a fungal meningitis, and proteins are slightly elevated. So if you will focus only on this report, there is a high probability that you might think it is a viral meningitis also. SS, we're not doing it at the moment, but anyway, you can mail me at marvamedicine@gmail. I'll let you know. The main point is, don't rely only on the lumbar puncture findings for these patients. The possibility of you getting that question wrong for viral possibility is very much there. So that is why we have a CRAG for diagnosis of this particular condition. And once we are able to nail down the diagnosis, then it is great. MRI findings तो I think सभी radiology अच्छे से पढ़ते हैं आजकल. So if he says what is the next best step for diagnosis of cryptococcal meningitis, next step and next best step, yeah doctor, I think they both mean the same. But in next best step, I can say that you have to choose between what is going to be the best for the patient, in a sense that since you were talking about that question of NEET PG, where we were talking about IV fluids and insulin bolus and IV fluids with insulin drip. मैंने वहाँ पे IV bolus नहीं बोला, मैंने drip बोला, क्योंकि patient को circulatory failure था. तो you have to take that in the consideration that if person is in shock, then insulin will not be able to act. So I think your question is primarily related to what we have discussed in our previous discussion. Absolutely, we do a MRI brain and we'll be able to identify a soap bubble appearance in this case. So great. and this would be anyway, the chances of this patient dying would be much higher. If soap bubble appearance has appeared already, there is a substantial amount of local damage in the brain which can cause problems for survival of the patient. Apart from this, when we do the chest x-ray of these patients, we can be exposed to this infection also, but immunity will kill it. But in this person, if you do x-ray, then x-ray it can either be normal, it can show bilateral infiltration, but it will not be revealing any evidence of any lymphadenopathy per se. So once we work out the diagnosis, we'll go into the treatment of these patients, and I can expect answers from you guys. Brilliant chaps, you studied pharmacology, so please let me know if person is having cryptococcal infection and this is occurring in an immunocompetent person, then what would be answered as drug of choice. So we will talk about AIDS positive patient in few seconds, but suppose the question is mentioning immunocompetent chap, then what is the drug that you should be answering? Yes guys, giving you a few seconds to comment about it. When to start prophylaxis? Aman, Anand, we started only if a person has had a single episode of cryptococcal meningitis, otherwise we will not be starting. Okay, I got good answer, liposomal amphotericin B and flucytosine. So if the MCQ simply says pulmonary cryptococcosis in an immunocompetent patient and he says what is the treatment, then do not answer all these fancy drugs like liposomal amphotericin B and flucytosine, because that is what has been discussed for a person who's immunocompromised. So if it's a plain pulmonary if it is a plain pulmonary cryptococcal infection, the reason why I'm telling you is most of the chaps here are going to be sitting for INICET subsequently. So if he just says pulmonary cryptococcosis in an immunocompetent patient, answer is fluconazole. But if it is extra pulmonary, now once it is extra pulmonary, it can spread to the skin, like he gave you that skin lesions present. So suppose he next time gives you a similar kind of a skin lesion and he says what would you be doing in this particular case, then for those cases extra pulmonary we'll be using amphotericin B. So it's only that you need to step up if it's an extrapulmonary manifestation. But if extrapulmonary is causing a CNS involvement, that is when your answer will be valid, what most of the guys were saying, that is amphotericin B plus flucytosine. So we need a graded response to be done in this case, and after that we'll continue with the flucytosine for another shorter duration. In fact, fluconazole for another shorter duration, that would be 400 milligram, and then we step down to 200 milligram in this patient, and this fluconazole in this person might be given even on a lifelong basis. So you need to learn the fact that in an immunocompetent chap it's a step up, it's fluconazole, extrapulmonary like a disseminated skin, it's ampho B, and then subsequently if it's a CNS involvement, that is ampho B plus flucytosine plus fluconazole. Now we move on to the right hand side. Yes, Bhaskar, sure, I will do that. I'll do that on Nurse Easy channel. Sure, I'll do that. And in case there is a question, now is the time for those classes actually, because you build up gradually. Last class में पढ़ते हैं सारे, हम साल के शुरू से start कर रहे हैं. Okay. As far as the immunocompromised state is concerned, if there is gonna be no CNS involvement, and he says what will you do for treatment, your answer would be fluconazole plus flucytosine. ध्यान रखना सर, मैंने amphotericin B plus flucytosine नहीं बोला अभी. आज का जो discussion है, that is mainly with respect to if it is gonna be immunocompromised chap, then we are gonna take fluconazole, flucytosine, and this is called as induction therapy. And then subsequently fluconazole will be given on lifelong basis for these patients. So right hand side pay, this fluconazole will be started on a lifelong basis. And Anand, you asked for that previous INICET question, when would you start? Though I've discussed that in the previous year questions, I'll still say that if somebody has already had an episode, that is when we'll start prophylaxis in the patient. And how to differentiate a case of lacunar stroke? Doc, you can be doing a CT head and you can get evidence of damage in the subcortical areas, and lacunar stroke would be having either a pure motor stroke or a pure sensory stroke. नॉर्मली तो ऐसे पढ़ते हो ना, हेमीप्लीजिया, हेमी एनेस्थीसिया, वहाँ पे क्या होगा, प्योर मोटर या प्योर सेंसरी स्ट्रोक के फीचर्स होंगे. एंड द एक्सट्रीम राइट हैंड साइड नोबडी विल मेक अ मिस्टेक, ये तो मतलब स्टैंडर्ड ही है कि एम्फो भी देना ही देना है, एम्फो बी के साथ में फ्लूसाइटोसिन भी देना ही देना, और उसके बाद में लाइफ लॉन्ग फ्लूकोनाजोल पे पेशेंट आ जाएगा. तो एक्सट्रीम राइट हैंड साइड इज नॉट द इशू विद सीएनएस इन्वॉल्वमेंट, इट इज मेनली विदाउट अ सीएनएस इन्वॉल्वमेंट इट्स गोना बी फ्लूकोनाजोल, फ्लूसाइटोसिन एंड देन फ्लूकोनाजोल लाइफ लॉन्ग basis. So that's one of the main reasons why I thought that I should come out with a quick video on this one. And then comes the concept of iris. Somebody mentioned पॉस्कोनाजोल, वोरिकोनाजोल. यार वो दवाइयाँ जो है ना वो मेनली एस्परजिलोमा में यूज करते हैं. तो पोस्कानाजोल वोरिकोनाजोल यहाँ पर यूज कर सकते हैं या नहीं कर सकते हैं? तो कर सकते हैं. वी कैन बी यूजिंग दीज मेडिसिन ऑल्सो, दैट्स ओके, बट देर इज नो रूल विद माइकाफंगिन, कैप्सोफंगिन एंड स्टेरॉइड्स, ऑब्वियसली अंडरस्टैंडेबल. एंड वुड यू गेट आयरिस? आयरिस की फुल फॉर्म टाइप कर दो एनीबडी क्विकली गाइस. वो पढ़ते हो ना आयरिस, तो आप टीबी के साथ में पढ़ते हो ना, एटीटी एंड कॉम्बिनेशन एंटी रेट्रोवायरल थेरेपी. सो आयरिस वुड बी इम्यून रिकॉन्स्टिट्यूशन इन्फ्लेमेटरी सिंड्रोम, आयरिस. तो क्वेश्चन है आप लोगों के लिए कि अगर किसी पेशेंट को क्रिप्टोकोकल इन्फेक्शन भी है और क्रिप्टोकोकल के साथ साथ में उसको एड्स भी है, तो पहले किसका ट्रीटमेंट स्टार्ट करेंगे? विल बी फर्स्ट स्टार्ट ट्रीटमेंट ऑफ एड्स देन अपग्रेड द इम्यूनिटी, और शुड यू फर्स्ट ट्रीट क्रिप्टोकोकल इन्फेक्शन? जरूरी नहीं ना उसको सीएनएस इन्फेक्शन है, मान लो उसको स्किन इन्फेक्शन है. सीएनएस है तो आप बोल दोगे कि भाई सीएनएस वाला ट्रीट करेंगे हम. मेरा क्वेश्चन आपसे, मान लो उसको स्किन इन्फेक्शन है एंड साथ में एड्स भी है, तो पहले किसको स्टार्ट करते हैं? मतलब पहले एड्स का ट्रीटमेंट देंगे, मतलब उसको कॉम्बिनेशन एंटी रेट्रोवायरल थेरेपी या प्लेन एआरटी स्टार्ट करेंगे, या क्रिप्टोकोकल इन्फेक्शन को ट्रीट करेंगे? सपोज अगर सवाल जो है वो है कि भाई आयरिस हो सकता है ना इसमें. हाँ जी, हाँ जी, यस रमीज, दैट वुड बी इम्यून रिकॉन्स्टिट्यूशन इन्फ्लेमेटरी सिंड्रोम. Saurabh, you made it easier for all of these guys. The basic point is we will first treat cryptococcal infection, then we will treat AIDS. यहाँ पे पॉइंट है एक और कि दोनों के ट्रीटमेंट के बीच में कितना गैप रहेगा. तो जैसे टीबी में हम पढ़ते हैं कि टीबी का ट्रीटमेंट पहले देते हैं और फिर एड्स का ट्रीटमेंट देते हैं, वहां पे जो गैप होता है वो 2 वीक्स का होता है. यहाँ पर जो गैप रखना है, दो सौरभ हैज ऑलरेडी आंसर्ड दैट इन द चैट, बट दैट्स ओके, दैट्स ग्रेट. आई मीन आई थिंक डायरेक्ट वो हैरिसन की लाइन है कि अगर वो टीबी और एड्स के बारे में पूछेगा तो आप आंसर करोगे. ये एफएमजी में भी क्वेश्चन आया था पिछली बार कि टीबी और एड्स दोनों है, पहले क्या दोगे? तो पहले टीबी का ट्रीटमेंट देते हैं. डिफरेंस बिटवीन द टू इज 2 वीक्स. बट इफ इट इज गोना बी विद रिस्पेक्ट टू अ चैप who's having cryptococcal infection and AIDS, then the gap between the two would be kept as 4 to 6 weeks. तो ये पॉइंट याद रखना. और अगर किसी डॉक्टर ने उल्टा कर दिया, लाइक इफ अ डॉक्टर स्टार्टेड पहले एड्स का ट्रीटमेंट, इम्यूनिटी अपग्रेड होगी, पर्सन विल डेवलप फीवर, चिल्स, राइगर्स, और वो पेशेंट आके लड़ाई करेगा डॉक्टर से कि सर आपकी वजह से मेरे सिम्टम्स वर्सन कर गए हैं, दैट इज गोना बी डेवलपमेंट ऑफ आयरिस इन अ पर्सन. सो आयरिस ऑलवेज डेवलप्स इफ अ डॉक्टर डज उल्टा, दैट इज फर्स्ट स्टार्ट एड्स treatment and then is gonna be starting the cryptococcal infection treatment. So in this particular case, in subarachnoid hemorrhage via regional wall hypokinesia, Dr. Hiren, what happens in subarachnoid hemorrhage is that there is a massive release of catecholamines, and that massive release of catecholamines is going to contribute to damage to the heart. So catecholamine toxicity would contribute to the problem in that case. So I hope that answers your query. So guys, my main focus was to talk about this treatment algorithm for immunocompetent and immunocompromised patients. The PDF of this would be available in the Telegram group. Testing, I think you guys are familiar with, nothing great about it. And yep, I mean, I did mention the fact that yep, CSF count can be deliberately normal given in this question, and meningeal signs may not be elicited. So any AIDS positive patient, headache, vomiting, we don't wait for nuchal rigidity, we don't wait for Kernick sign, we don't wait for Brudzinski sign to develop, and we can be we can think in terms of cryptococcal infection. And cryptococcomas, again, granulomas could be developing in the lungs. That's an additional point which I forgot to say कि lungs में जो granulomas बनते हैं, those granulomas are caseating granulomas. TB treatment with respect to CD4 count, doctor, if CD4 count is less than 500, no, if person is taking card, then problem will not occur. So we have to anyway start ATT in a person. The only thing is rifampicin will not be given. That's because we'll substitute that with the rifabutin, because the interaction of rifampicin with protease inhibitors. Okay, Dr. SS, I'll do that in a separate session. Today was more of an academic one, so I thought that I should handle this query because I was getting a lot of pings with respect to, I mean, you know, suddenly they start putting up fungal infections. I said, okay, let's handle this. So, I mean, okay, I know you would have read about all this from even your microbiology part, but if you can just brush through this a quick, maybe at 2x, if it's a 30 minutes video at 2x, maybe you will be able to complete this and do relatively better. Okay, Ramesh, I'll definitely do that. I'll revert back to your query. And yeah, thank you so much, guys. This was a quick discussion on Cryptococcus today. And I'll be coming with much more longer discussion subsequently, but this was more of an urgent one because I had a couple of students saying, sir, we need a quick input with respect to this since it was asked, and I think I've tried to do justice to that. So do have a look at it. I mean, do read about these aspects even from a microbiology, and you're gonna do great in your careers. So I'll just take up a few more queries if you have, and then we'll call it quits for today. थैंक यू डॉक्टर अंशु. ये थोड़ा देख लेना आप लोग, है ना, गेट आई का, क्रिप्टोकोकस न्योफॉर्मेंस का, ऑल दीज एस्पेक्ट्स, दे ट्राई टू आस्क दीज एस्पेक्ट्स व्हेन दे टॉक अबाउट एड्स पॉजिटिव पेशेंट्स. ओके, great. So thank you so much, guys. Thank you for your patience and joining me today. And sure, I'll be back with much more longer discussions. God bless you. सर, इन टेलीग्राम ग्रुप में ना सर मजाक होता है, उसमें कोई क्विजेज नहीं होते हैं. मैं फ्रैंकली आपको बता रहा हूँ, अगर आपने रियली में उसको करना है सॉल्व, तो आप क्या करना कि मेरे ही चैनल पे लाइव सेशंस हैं, उन लाइव सेशंस के जो क्वेश्चंस हैं ना, उनको जब करोगे तो आपको समझ में आएगा कि दे लॉट ऑफ टेक्निकल एस्पेक्ट्स. Sure, Anand, I said mail me the list and I'll solve it for you. So just let me know the list and I think I'll be able to do justice. Okay, thank you guys. God bless you.